The following podcast is part of a certified educational activity titled The Road to Remission in Multiple Myeloma, Expert Guidance on Using BCMA-Targeted Options to Enhance Clinical Outcomes. Access the entire activity and complete the post-test at peerview.com/KTZ860. Downloadable slides and practice aids are also available.
Our focus today is to understand the road to remission in multiple myeloma through BCMA-directed treatments. I'm Nikhil Munshi from Dana-Farber Cancer Institute with my two esteemed colleagues, Dr. Nizar Balis from University of Calgary, and my friend and colleague, Dr. Balis is my friend too, Dr. Irene Gabriel, also from Dana-Farber Cancer Institute. So BCMA has become a very important target. The fact that all of you are here, I don't have to describe BCMA as much. There are two critical characteristics which makes it a good target. One is that it is specifically expressed on plasma cells and myeloma cells, but not elsewhere in the body. And number two, it is involved quite significantly in a signaling pathways in myeloma through its ligands BAFF and APRIL, and that leads to NF-kappa B activation, cell proliferation. So myeloma is to an extent dependent on BCMA and its presence and signaling, and so myeloma cells without BCMA is quite uncommon. It's not zero, but it's quite uncommon, and that makes it a very good target. And blockade of BCMA, either using a directed therapy or delivering a drug, has become an important area for research for all of us. Now, when BCMA on the cell surface is presented, there's an enzyme called gamma secretase, which clips it, and you can get soluble BCMA. And the soluble BCMA does reflect part of the myeloma presence or the myeloma burden. So in one of the studies, it was shown that there is an increase in soluble BCMA from patients from early stage disease to multiple myeloma and a relapse disease. So there is a relationship with soluble BCMA level. The second important point about soluble BCMA, and this is, I would predict that this test is going to be becoming one of our tests to be done in a near future when commercial tests are available. And that's when it's good to know about soluble BCMA, but its level also predicts the outcome, both progression-free and overall survival. So in this particular study, if you look at patients, around 200 patients were studied. If you look at the median, patients who were below median, their PFS was 9 months. Patients who were above median, their PFS was 9 months. Patients who were on the other side, theirs was 3.6 months. For overall survival, those who are below median, 155 months, thinking maybe it's a low tumor burden or may reflect the biology. And patients who were above the median for soluble BCMA, it was 98 months. So significant difference between the two groups. So soluble BCMA, there is connection with disease progression. There is connection with both progression-free and overall survival. But quite importantly, it also tracks very similar to the traditional myeloma markers. So we do serum free light chain and other markers. Soluble BCMA, in these two examples shown here, one of them is soluble BCMA, the other one is light chain or M spike. And you probably are not able to read what it is because it doesn't matter that both the curves are exactly tracking. And so in patients who would have non-secretory disease, less secretory disease, soluble BCMA may become one of the markers for following the disease. It's independent of renal function, so there is some benefits to it. And there is some relation with immunodeficiency that in future we would all study and see how to overcome it. So because of this great importance of BCMA as a target, there are 4 drugs which are approved in multiple myeloma, specifically targeting BCMA. Belantamab mafodotin is an anti-BCMA antibody, which is tagged with a drug. Now, because of a recent data with DREAM3, where the drug was not superior, it was equivalent, not superior to the control arm, the US regulators have asked that belantamab be withdrawn from the US market. However, there are studies ongoing, and you will hear about those that will be interesting enough to follow. There are 2 CAR T cells, one in 21 and one in 22 approved, IDO Cell and cilta-cel. And then very recently, teclistamab which is an anti-BCMA CD3 antibody, the bispecific antibody, which is approved. And the common theme which you see here is that all of them are approved as patients, in patients who have received more than 4 cycles, 4 or more cycles. So this becomes a fifth-line treatment. And one of the things for us to discuss would be, what does fifth line mean in myeloma these days? We have so many drugs, but how do we get patients to this? And that would be an important point for our discussion. Now, despite all this super progress, we have challenges. If the drug is available in the fifth line, there's very clear data. One study in 22,000 patients showed that large majority of the patients do not even get to beyond first line, and because of the disease, because of various factors. So we need to bring these good treatments earlier on. And one of the themes for us in discussion today is, how do we bring this to or are we bringing it to earlier setting of the disease? In another study, 21% patients got transplant and nothing beyond. And so there's a clear need to do something sooner and do something earlier on. And finally, when patients go to fifth line, they have a really refractory disease. They're really multi-refractory disease. In one of the studies using the real-world data, it was shown that almost 1/3 of the patient with triple-class refractory disease, they did not receive anything. So that's one point. The second one which is being presented in this meeting is that patients who are penta-refractory, the graph on the left side shows that, who are penta-refractory has the worst outcome, tri and quad refractory has intermediate, who are not triple refractory has a better. So even the outcome is better when you do treat patients earlier. So this is another ongoing theme. We need to get the drugs to the patients, and it's better to treat them early because we get better results in those patients, and they really need it. So this is the backdrop of what we are going to discuss today. So our agenda basically is to explore the evidence and the data we have about CAR T-cell therapy and how practical and feasible it is in the practice. The emerging role of BCMA antibody therapy, and there is a significant high level of responses. And then finally, the rapidly evolving use of this therapy earlier on in the disease setting, the emerging future use of this therapy. So this is how our today's discussion is set for us to understand where we use. Now, Health Tree Foundation for Multiple Myeloma is one of the partners in organizing this symposium. We are thankful to them for building the community and advancing the research focused on multiple myeloma. So with that, I would lead off with the first presentation. And my focus is going to be basically use of CAR T-cell therapy in relapse refractory multiple myeloma. Now, as I mentioned, there are 4 drugs approved. All of them are approved in patients who have had 4 or more lines of therapy. This is part of the NCCN guidelines. It's part of every guidelines, how and where it should be used. In the United States, the use is partly determined by what the insurance pays for it. And because it is the fourth and beyond line, this is where patients are being treated. Now, there is one additional drug for this line, which is selinexor with dexamethasone, also approved for patients who have received 4 or more lines of treatment. Now, when we talk about IDO Cell, it is the first anti-BCMA CAR T approved in 2020. The construct is very similar to most of the usual constructs are. It has 3 components. The one in green is the tumor binding domain. That's what leads to binding of the CAR T to the myeloma cells through BCMA. The second component is 4-1BB. It's a co-stimulatory molecule. And the last one is CD3 zeta, which provides the T cell to have more proliferative advantage when the CAR T myeloma cell binds. So in short, what happens is that when T cells are transduced, and it takes around 4 to 6 weeks to prepare this T cell, and that will be one of the points for our discussion later as well. It takes time. We need to give bridging therapy and other to hold the patients. But when the CAR T cells are given to patients, the CAR T seeks the myeloma cell, binds to it, and in the process does 2 things. It kills the myeloma cell on one hand, and the CAR T cells begin to expand through the signaling transmitted through CD3 zeta. And this expansion can be up to 5 to 6 log, and that is critically important for good functioning of the CAR T cells. Now, there were earlier promising study in phase 2, phase 1 studies with almost 90% response rate in a very late patient population. And this led to the more definitive, the registration trial, KarMMa-1 trial. It basically looked at responses primarily and then PFS in triple class refractory multiple myeloma population. And standard criteria for responses were used to measure it. Overall response rate was 73%. In the target dose, which is what we try to give it to the patient in the commercial side, is 450 million cell, where the response rates were 81%. Close to 40% patients achieve complete remission. So a very high number of patients. Now, the patients population who got this treatment had, on an average, 6 lines of treatment, and they were 6 years from their diagnosis. They all were exposed to all the 3 agents, PI, immunomodulators, and CD38 antibody, and resistant to the last line. So very advanced patient population, getting 80+ response rate, 40% CR rate, and that was the most exciting part. The responses with CAR T cell are extremely quick. We currently, because of the study parameters, all these are part of the study. In the clinical practice, we don't keep the patient in the hospital for 2 weeks. A shorter time is safe enough. But when they stayed for 14 days, when the patients are being discharged and we measure their myeloma numbers by 14 days, they already have a clear evidence of response, sometimes very profound response. So median time to response overall is 1 month, which is the official time to measure it. And to get a CR, it's close to 3 months. So in 3 months, patients who are going to get CR would have gotten CR. Now, it's a median. The follow-up for this study is around 13 months. And if we look at the outcome of this patient population, the overall PFS is 8.8 months, but the PFS improves and the overall survival improves with deeper response and with higher dosages. So patients getting 450 million cells, the median PFS was 12.1 months. And for patients who got complete remission, the PFS is around 20 months. And so getting a deeper response is critical in achieving a longer and more sustained response in this patient population. There is a poster in this ASH which is going to discuss achieving MRD negativity, for sustained or longer remission. If you look at overall survival and look at patients, how many lines of treatment did the patients get? 3 lines, 4 lines, and all of the patients, you could see that the median overall survival ranges around 2 years for all patient population, keeping in mind these are very advanced patient populations. So very exciting results for this particular CAR T product that is now commercially available. If we compare what are we doing in the real world right now, the studies are good. They're done in a very specialized center. Most of the time, patients who are, doctors who are treating the patient know what they're doing, and you get better results. What happens when the commercial product is available? So if you look at the real world data, one thing, more sicker patients are going on the study, partly because for studies, we had very clear lines about renal function, about blood counts and other things. In real world, we can cut corners, we can utilize certain other, leverage certain other abilities. And so if you look at the real world data, it also shows 2 things. One is we can safely deliver the drug to large number of patient population, and that we are treating significantly sicker patients, but the results are very similar. And so then the real world, patients were divided into those who were going on study and those who did not go on study. Both of the groups showed very significant improvement in PFS, which is very important for us to now utilize this, as some of us have been already utilizing for a while for clinical purpose. The second CAR T product, which was approved in 2021, is Cilta-cel. The study was CARTITUDE, and the construct here is slightly different. The 4-1BB and CD3 is same, but the BCMA binding domain, there are 2 BCMA binding domain, and that's a unique nature of this construct. And with that, this particular product was also evaluated in very similar advanced patient population. Median lines of treatment 6, also 6 years from their diagnosis, with everyone exposed to all the 3 classes of agent and resistance to most recent agent. And using this construct, the overall response rate was close to 98%, and 82% patients received stringent CR. So very deep responses, and almost everyone responded in this study. Now, when we look at this very positive result, as you will hear in the subsequent talk by Dr. Gabriel, that we are now beginning to use this earlier in the lines of treatment because of the efficacy that we see. Very importantly, when we look at what is the survival in this patient population, and what we observe is that, again, deeper the response, you see better outcome. So there are 4 curves here. The topmost dark blue curve is patients who are MRD negative at 12 months or greater. So you could say more sustained MRD negativity. And there is a presentation abstract on this subject as well. And so sustained MRD negativity, the PFS at 27 months, more than 2 years, is 80%. So 80% patients are still not relapsed in that setting. The next curve is MRD negativity for 6 months or greater. The blue curve, the third curve from the top, is stringent CR. And then when you take all the patients, the curve you see is that even for all the patients, whole group, PFS not been yet reached, and 27-month PFS is 55%. So very, very exciting that not only deep responses, but the responses are durable over time. And that is the great excitement about a 6th or beyond line of treatment that patients received. Overall survival, similarly very exciting results. If you look at all the patients for overall survival at 27 months, it is close to 90%, median has not been reached, 70%. And for patients who are MRD negative, it is 90%. And so again, overall survival is still being continued for follow-up. We haven't reached the median yet. And as you would see similar data on lymphoma patients and lymphoma colleagues who present, and I feel very jealous about that because they begin to show a straight line in their curve. And I'm hoping that some of this curve give us a couple of years or maybe, a couple of years of follow-up, and we might be able to show a straight line at some level. My prediction would be 25 or 30% patients hopefully may not be relapsing after a certain time. We'll have to wait for that. So now if we go to the CARTITUDE data, it's important to keep in mind that all the groups respond, and MRD negativity is induced regardless of whether they're high-risk stratification or high-risk cytogenetics, their ISS staging system, or their past treatment history, what they have received. And if you see the curve on the right side, you could see the similar curve here for PFS for MRD negative, which is sustained 6 months and lesser. There are 2 features which come into picture, which may affect that. One is extramedullary disease. It has always been an issue with every treatment. Although those patients respond, we have to follow them further. We have work to do to keep them in remission, or more importantly, attain MRD negativity in those patients. And another feature is time since diagnosis, which may be critical about what they were exposed to. And we have to keep that in mind as we consider treating patients very late in the disease. And that is why treating them early might end up getting us that straight line that we are looking for what would be a curative outcome in this patient population. Now, if you look at the real-world data for cilta-cel, what's called Locomotion Study, big difference. I mean, this is a curve where we don't need a p-value. If you look at patients who got cilta-cel versus those who are in real-world population, there's really no comparison. Hazard ratio is 0.15. So extremely effective in the patient population who got treated with it. And it is almost where we cannot deny patient the type of treatment and responses they would be getting. Now, there are a few things to keep in mind in this patient population. That the treatment is effective in almost all the disease group. So if you take a patient who has extramedullary disease, and this is the IDO Cell data, the data for cilta-cel is very identical. So extramedullary disease, you see similar responses. Patient with cytogenetic risk, high versus not high, similar response, no significant difference. Tumor burden, which is one of the concerns we had before, doesn't pan out to be the case. The only one where we have consistently seen difference is patients who are RISS 3 versus RISS 1 and 2. 3 gets lesser response. It's still 50%. And this is reasonably across the board, except it is less than the patients who are ISS stage 1 and 2. And that's for us to understand why and how can we overcome this. And finally, a number of prior regimen, although we believe for MRD negativity, that may matter. For general response, 65%, 81%, it was not statistically difference between the two with overall response rate of 73%. So we have to keep in mind that, that all types of patients, there is no class of patient population that may not benefit from CAR T cells application. And the second point, which is critically important for all of us in practice, is that it can be also given to patients at all different age group. It can be given to young and it can be given to old. I mean, we know our old algorithm, transplant eligible and transplant ineligible. And in one of the meetings we had yesterday, that differentiation is almost disappearing with the use of transplant the way we do, and it is still very important part of our treatment. The age and other differences, the utilization of CAR T cell, etc., is blurring that boundary about who is eligible, who is not. And the reason being that CAR T can be given safely to patients beyond 70. We have all treated patients 80 and slightly above 80. So 80 is the new 70 or new 30. But I think 80 is the new 70 for us as far as CAR T is concerned. I was trying to say, did I say opposite of what it should be? And what the data shows here is that if you look at the patients who were more than 70, patients who were more than 65, and overall, the response rates are very similar. Yes, the number is higher. I wouldn't call it better. They're very similar responses. And if you look at the CR rate, it's also very similar across. So for this patient population, even above 70, you can really get good and deep responses. And currently, the CAR T cell treatment is one and done. That's a catchphrase for people who work on CAR T, one and done. You get CAR T, there is no maintenance. And of all of us who have treated these patients, the patients are thrilled. They do not get any maintenance. They do not need anything for a prolonged period of time. And they have been always on something for all their 6 lines of treatment, and all of a sudden they're free of treatment. So that's a very interesting component that patients love. And I do tell my patients that although that's really a good thing in my mind, we may need something after you get a super response to CAR T. In the studies, we did not do it. In practice, I think we are working on things to shorter duration, not forever, but some maintenance, because when you get 98% response rate, and 80% CR, 50+% MRD negativity, I don't want that patient to relapse. We can sustain their remission. We can sort of cure them. So stay tuned for what maintenance, that's another area of discussion. But currently, it's one and done, and patients feel great. So for older patient population, great responses. But also, if you look at their toxicity, no different than the younger patient population. The concern one would have, do they have a, because of their whatever cardiac risk factors, renal risk factors, and other, do they have a greater issues, and is there any mortality? There's no difference in neurotoxicity, practically speaking, really no significant difference in CRS, and really no major impact on the grade and the treatment and the tolerance. And so we can treat older patient population very comfortably, and we'll discuss this further in the case that we are going to discuss. Now, the last point is that this cilta-cel is active in high-risk relapse refractory myeloma. So CARTITUDE-2 studied multiple cohorts, and you will hear some other cohorts later on. Cohort B was where with these patients were studied in patients in home who had early relapse, less than 12 months from their transplant. And by definition, people would relapse quickly. Whatever their cytogenetics, we know functionally they are high-risk myeloma patient population. And even in those patient population, response rate was close to 100 or literally 100% here, and CR rate was 90%. So even in high-risk patients, patients who have had limited response to high-dose chemotherapy after the initial induction, they do well. So I think we have to keep that in mind. So there are certain general principles to deliver CAR T cell therapy. The dose is standard for both the products. We have to decide which patients to refer when, how to infuse. There are specialized centers doing it, so people in practice don't have to worry about how to infuse, but there are standard practices. We don't want to use dexamethasone earlier on because it can impact T cell function. And there are certain side effects we need to keep an eye over a period of time. The administration is very straightforward. Lymphodepletion, usually with cytoxan and fludarabine. I said usually because there was a shortage of fludarabine, we gave bendamustine. Patients are pre-medicated. We monitor their CRS and ICANS, and depending upon the product, they stay in the hospital for a short period. Currently, many centers are now trying to do it outpatient, and it's available through a specialized program. Now, if you look at toxicity for both the products, very similar. CRS, the time of CRS is different. Day 1, IDO Cell, day 7, cilta-cel. That determines how long they stay in the hospital. IDO Cell I would admit initially, cilta-cel I could do it later. General neurotoxicity is similar, infection risk is similar, cytopenia more or less similar. Cilta-cel had delayed neurotoxicity. However, with mitigating measures, decreasing the tumor burden before they get cilta-cel has eliminated that, but we still keep an eye on that. There are many other products ongoing, and some of them are listed. They are in phase 2, far enough, including allogenic products. And the final thing is, what next? I mean, this is great. How can we cure? There are a lot of plans ongoing for curative outcome. We are trying to improve the construct, dual CAR, RNA CAR, peptide-stimulated T cells, etc. We are also trying to generate the CAR T cells with certain characteristics. CAR T cells which may have memory phenotype, so they persist for a long period of time, sort of self-maintenance. There are allogenic CAR products. And there are CAR studies, one of them being presented here, where the CAR T cell can be made in 2 days, so very short production time. These are all going to make it much more easier for us to use. Then gamma secretase, it clips BCMA, becomes soluble, but the cell loses BCMA. So if you use gamma secretase inhibitor, you may be able to increase the BCMA, and there are ongoing studies to show that. And then we have to improve the protocol. That's also for discussion. Do it earlier on, do it in a way that gives us the best cytoreduction. We can give it with immune stimulators, the traditional inhibitors of the immune inhibitory or immune IO drugs that which we have, pembrolizumab or nivolumab or others. And these are the ongoing studies. So stay tuned for really having a great new lines of treatment that are going to come about in next few years. The future is very bright for getting the patients in remission. Now, I will present a short case, and then I'll have my 2 colleagues, and with me included, we would discuss and see how that real-life patient can benefit, or would he benefit from CAR T treatment. So Robert is a 71-year-old gentleman. He had a standard risk, but ISS2, relapse refractory myeloma. He got treated with RVD, induction, transplant, and maintenance. And this was almost 5+ years ago. So he was at that time younger than 70. 3.5 years later, he progressed and received carfilzomib cytoxan dex, achieved VGPR. A year later, when he progressed, he got daratumumab, pomalidomide, dexamethasone. And then 8 months later, he progressed and got selinexor, Velcade dex. And what you see here, and it's very emblematic of how the disease behaves, the first remission is longer, the next is shorter, and the third is shorter than that. And so this is what you keep on seeing. This chain is usually now broken by the immune therapy. The patient had an ECOG performance of 1, and serum creatinine of 1.5. So to give my throat a break, I'm going to ask my colleague, what do you think about this patient's eligibility for CAR T cell, keeping in mind in age, disease stage, and renal function?
Definitely this patient would be an excellent candidate. To summarize, he's a 71-year-old quad refractory, or actually penta-refractory, including selinexor as well, has an excellent performance status, adequate kidney function. We haven't heard much about his medical history, whether he has any comorbidities as far as cardiac dysfunction or other illnesses. But from what we heard, he appeared very healthy. Any performance status is one. Again, as you mentioned, Nikhil, age isn't a factor for CAR T cell therapy as long as the patient is fit and has adequate cardiac function with no comorbidities. And based on the data you showed us this morning, CAR T cell therapy showed improvement in outcome regardless of age and equal benefit regardless of age as well. So in my opinion, yes, definitely this patient is an excellent candidate.
Yeah, I mean, I absolutely agree. I think, as you said, 80 is the new 70, so maybe 70 is the new 50, I guess. But age is truly just a number, and we should not be using age to look at CAR T. In fact, maybe for stem cell transplant, we're using age as a surrogate of the performance status as well as the performance of those patients. Will they do well? Will their organ function do well? And so on. Now with CAR T therapy, we think that this can be done in any age and potentially even with some organ dysfunction as long as you're careful with those patients. And it's impressive how we're improving on it, we're understanding it better. The one thing that we can do better is have it available for everyone. And I think that availability for our patients so that they can access the best care is important, especially for the diversity, for all of the inclusion for our patients.
So to add to that, I think the creatinine that we just mentioned, we have treated patients who have had creatinine of much higher than this, 4, 5. We have treated 2 patients who were on dialysis with a commercial card, not in the study basis, although there is a plan to have possibly specific study in patients with renal failure. The point is, 1.5 is not bad creatinine in general, although he would not qualify for study. For commercial purpose, he'll be a very safe patient. So I think we can have a reasonably leeway, let the specialized center decide if the patient is just having high creatinine should not be considered as an exclusion from such treatment. And as you say, age, just a number. We have treated 80-year-old with no issue at all with CRS and other things. Now, the disease stage, I guess every disease responds. So we are not concerned if it's stage 2, stage 1, or stage 3. I think this is the best treatment for this patient. So the point comes up for a referring physician. When can our referring physicians begin to think about CAR T cell? The requirement is patients should have had 4 lines of treatment or more, so that remains. But should they wait that long, or is it preferable where we can plan earlier on?
I guess it depends on the country where you practice and the indication for CAR T cell therapy. But the clinical trials so far that led to approval all required at least triple-class refractory patient or at least 4 lines of therapy. Now, as far as referral, the one information missing from this patient is the kinetics of his disease progression. And that's what I guess Nikhil is referring to. Because if the disease is rapidly progressing, you want to allow yourself enough time to allow the manufacturing process to take on. As you know, CAR T cell therapy requires T cell harvesting, transduction of these CAR T cells in the reference lab with lentiviral particles to induce the CAR T cell expression. And therefore, the process typically takes at a minimum 4 weeks, sometimes more than that, up to 6 to 8 weeks. And therefore, yes, we have to plan. If you have some patient you are planning to refer them for CAR T cell therapy, please do not wait until they have rapidly progressed and M protein significantly increased and deteriorating. Plan the referral earlier to a referral center, which gives you time to use some bridging therapy and then transition them to the CAR T cell therapy, basically.
Well, I want to say thank you to Nikhil Munshi for leading an IMS FDA meeting just a few weeks ago. And if any of you have not attended it, try to see it virtually, because it really was an amazing meeting where we learned a lot from how the FDA looks at lines of therapy and at the regulatory requirements of how many lines should our patients receive before they receive their CAR T or their bispecific. And it was truly eye-opening for us to see how we can really change the way we think. And that word of lines of therapy is so hard for us. There is no meaning to it. So we need to change that. And as academics, as pharmaceutical companies and the FDA, we need to change the way we think of it, because our patients are not going to wait for the 4th and 5th line. If they've been exposed to the drugs and they need the CAR T, you will see that the data, the sooner the better, the less tumor burden, the better. So let's try to change that and not wait for people to have 4 or 5 lines of therapy and then we treat them.
Yeah, we give 4 drugs as induction, I mean, what's there left for the fourth line? Sometimes we joke that we have to give placebo as another line before patients go to CAR T cell. Then one more thing to keep in mind also is that sometimes the last treatment can impact the type of cells we collect to make the CAR T cell. It's not yet a clear science, but there was some data, for example, we don't use the drug as much anymore, but bendamustine, if given as a last line before the CAR T cell are collected, the T cells don't function as well. So there is something to what patients should get as a last line treatment. Again, it's still evolving, but I would avoid a true cytotoxic drug unless one has to. And as Dr. Gabriel and Balis said, I think patients, how fast the patient is progressing is very critically important. Now, this patient got CAR T cell at a specialized centers, and this is where CAR Ts are done currently. And patient had a grade 2 CRS. And this should be a quick question for us, but any thoughts on, grade 2 CRS was because of fever and low blood pressure. So any thought on managing this patient? He's 71. How aggressive should we be? And when patient goes back to physician, can we keep it in mind?
Yeah, absolutely. I mean, managing CRS guidelines are very clear now, and it's been studied extensively. For this particular patient with grade 2 CRS, you want to start by giving this patient antipyretic. And with the grade 2 CRS, I would very promptly use tocilizumab in this patient. Typically, this would rapidly resolve within 1 or 2 doses. Tocilizumab dose of 8 milligram per kilogram, up to 3 doses typically tend to resolve these symptoms. If this patient was younger, I'd be even tempted to use antipyretic initially alone and wait for the first 8 hours, see how he does progress, and then add tocilizumab if his symptoms don't resolve. But the fact is a little bit older, I would probably be more prompt to use antipyretic with tocilizumab immediately as these symptoms occur. And in our experience, I mean, this tends to resolve 90% of these symptoms very rapidly within the first 24 hours.
Yeah, I mean, I totally agree. I think in the older days, just a few years ago was the older days when we were also scared of CRS, and now we know how to manage it. And in fact, many people are starting to advocate to use TOCI earlier and earlier, even in grade 1 in some patients, just to avoid getting into higher grade toxicity. So again, we will learn better. We will have all our experience put together, but TOCI is a great drug to use in many patients.
And there's one more point about this patient, that when this patient finished the CAR T, had a very good response. When he went back to his physician at 2 months, he got fever. And the last point I would like to make, and which we should all keep in mind, especially our physician in practice who will be receiving this patient after the first month. That's the time when patients are followed at the specialized center where CAR T was infused, is what do they should be looking for? And would you want to give an advice on what the physician in the practice should keep an eye on patient about? And obviously fever and infection are the top of the list.
Yeah, absolutely. As you mentioned, Nikhil, infection is a high risk for this patient population. As Nikhil mentioned at the beginning, BCMA is universally expressed in all plasma cells, including normal and clonal plasma cells, as well as some late differentiated B cells. Therefore, you'll see in all the patients receiving CAR T cell therapy or BCMA targeting therapy, you see a significant hypogammaglobulinemia. So you are dealing with a patient who is quite immunocompromised from a B cell humoral immunity. But also keep in mind these patients receive fludarabine and cyclophosphamide for the lymphodepletion, so the T cell immunity is also impaired because of that. Therefore, it's very important to give these patients IVIG on a monthly basis. That's our practice, to maintain their gamma globulin above 4 milligram per liter or 0.4 milligram per deciliter to prevent infection, use of Septra for PJP prophylaxis. And we typically use also antifungal therapy as long as the patient is neutropenic. Once the neutropenia recovers, you can discontinue antifungal therapy. The good news that in most of these patients, they recover their hypogammaglobulinemia. It varies between 6 months, a little bit longer, but that can reflect the activity of the CAR T cell in these patients.
Now it's my pleasure to introduce my friend and colleague, Dr. Nizar Balis, and he's going to be discussing the use of BCMA antibody drug conjugate and bispecifics in the same setting, targeting, of course, BCMA. So, Dr. Balis.
Thank you, Professor Monche. Good morning, everyone. Thank you for the early risers. I know some of you are traveling from abroad, from Europe, or from somewhere in Asia as well. So I'll be discussing this morning the role of BCMA antibodies in the form of antibody drug conjugate, ADCs, or bispecific antibodies. I'm not going to rehash the data in details, but in the next 20 minutes or 30 minutes or so, I'll give you some general guidelines what the difference between these molecules and how we can potentially use them to improve the outcome of myeloma patients. As Nikhil showed in the slide, the NCCN guidelines does reflect that there are now at least 4 molecules targeting BCMA approved for the treatment of relapsed refractory multiple myeloma. And of these, 2 are antibodies. One of them in the form of an antibody conjugated to a toxin, belantamab mafodotin, and teclistamab, which is now approved as a bispecific antibody targeting BCMA and CD3E on T cells. But how do we use these antibodies, and why do they work in general, bispecific antibody? What the mechanism by which they induce cytotoxicity either as a ADC or as a bispecific antibody? Starting with belamaf, as I mentioned, belamaf is a monoclonal antibody targeting BCMA and has been conjugated to a toxin, in this case MMAF, monomethyl auristatin F. Once belamaf or belantamab binds BCMA, it is internalized, and the payload, in this case again MMAF, is released into the cells. MMF is a microtubule toxin, so it interrupts the cell's function, leading to cell cycle arrest and apoptosis. But not only that, the FC portion of belantamab is still active in the sense that macrophages or monocyte or NK cells can bind the FC portion through the Fc gamma receptor and induce antibody-dependent cellular cytotoxicity, but also antibody-dependent cellular phagocytosis. And all that leads to immunogenic cell death, and therefore belantamab has been studied in combination with other molecules like bortezomib or immunomodulators because of this induction of immunogenic cell death. Now, there's a universal toxicity, unfortunately, related to all antibody-drug conjugate, which is ocular toxicity. And this mostly results from the release of the payload within the corneal space that leads to toxicity to the corneal keratocytes. How about efficacy? There have been multiple phase 1 and phase 2 trials. The DREAM2 trial was summarized by Sagar Lonial, showed the belantamab is clearly effective in triple-class refractory multiple myeloma with an overall response rate of 32%, including roughly around 20% very good partial remission or better. As you can see also in the Kaplan-Meier curve, these responses were clearly durable with a progression-free survival of 11 months, and the median duration of response was again 11 months. And this will be updated at this meeting by Dr. A.J. Nuka, showing that duration of response is actually 12.5 months. So very promising data with the first BCMA targeting antibody-drug conjugate showing durable responses in patients who are largely triple-class refractory or penta-refractory multiple myeloma. Now, as I mentioned, ocular toxicity is a challenge in this patient population. Our patients often have already some corneal toxicity resulting from their previous exposure to dexamethasone. They do have some cataract. And in these studies, we did see a high rate of keratopathy, around 72%. And around 56%, they had more than 2-point decrease in the visual acuity, and 18% the visual acuity was down to 20/50. However, this keratopathy led to treatment discontinuation in less than 5% in 3% of the patients. Now, important to note that keratopathy can occur with or without symptoms. Therefore, the guidelines in general, even though there's some clear guidelines when to continue or discontinue therapy based on the presence of keratopathy, in my clinical practice and when I use belantamab, I really guided by symptoms, because often when you do the ocular exam, you do see a significant degree of keratopathy, but it doesn't correlate necessarily with the patient symptoms. And it's important to know that keratopathy is reversible with drug discontinuation or drug interruption, and patient can resume therapy thereafter. Now, unfortunately, as we heard from Nikhil, the DREAM3 trial, which was a registration trial planned to lead to the approval of belantamab in the US and other jurisdictions, the study was designed to compare belantamab as a single agent given every 3 weeks to pomalidomide with dexamethasone 4 milligram. Despite showing a significant difference in progression-free survival, at least clinical difference, I would say, 11.2 months in favor of the experimental arm with belantamab versus 7 months for pomalidomide, the study did not meet its pre-planned statistical significance, and the hazard ratio was 1.03. And with that, unfortunately, the GSK has discontinued development of mafodotin, at least withdrawn mafodotin right now from the US market, awaiting other trials, as Nikhil mentioned. But no doubt this molecule has a clear role to play in multiple myeloma and activity in multiple myeloma, and hopefully with the next combination trial, we can demonstrate a significant p-value leading to its approval in relapsed refractory multiple myeloma. How about bispecific antibodies and how they induce cellular toxicity? The concept of bispecific antibody is really fairly simple. It's physical proximity between immune cells and your target tumor cells. In this case, shown in these two cartoons on the right, shown a true BiTEs, which stands for bispecific T-cell engager. These are two very small molecules where you took the Fab portion of antibodies, in one case targeting CD3 on T cells, and the other one in this case targeting BCMA or other myeloma-specific molecules. Or it can be a full antibody, as you can see on the right side, in the form of full antibody as duobody or bispecific antibodies that again target the BCMA or CD3. What are the differences in these molecules? I'll show that in the next slide. I'll discuss them in more details. But again, the difference in the structure, the difference in the valency, and the difference in the FC portion as well. So shown in here in this table, I try to summarize some of the available bispecific antibody, and the list is much longer than that. I try to make it as simple to fit into one slide. We have multiple molecules, at least 8 of them now, targeting BCMA. We have at least 3 molecules targeting GPRC5D, and we have 1 molecule, or actually now 2, targeting FcRH5 as well. Again, as I mentioned, bispecific antibody differ in the structure of the antibody. It can be, again, a very small BiTE without an FC portion, or it can be a full antibody with an FC portion that's been modified, either mutated or not, and FC still active or not. They also differ in the CD3 affinity. And that's one area where kind of counterintuitive. You want the CD3 not to have very high affinity for the FAB portion, not to have very high affinity for CD3. Otherwise, it will lead to trapping of the bispecific antibody in the serum and doesn't reach its target in the tumoral bed or tumoral tissue or the bone marrow. Therefore, it was desirable for this bispecific antibody to have low affinity for the CD3 moiety on T cells. To the contrary, you want the other half of the antibody to have high affinity for your target, whether it's BCMA or GPRC5D. These molecules also differ, as I mentioned, by the structure. They can be symmetrical, meaning one arm has the same size as the other arm, or they can have one arm longer, having two valency, for example, 2 molecules targeting BCMA, as we see with cell-to-cell, for example. And they also differ by the FC portion. The FC portion can be a naked FC structure, or it can be mutated FC structure. And the mutation of the FC portion has the goal of improving the half-life of the molecule and avoid also activating macrophages and monocyte to avoid some of the cytokine release syndrome and killing of the T cells as well. So you can see for teclistamab, for example, it's a BCMA CD3 antibody. It's an IgG4 antibody. And you can see also IgG4 is commonly used because normally IgG4, even in our body, tend to swap the Fab portion. So it's an easier molecule to manufacture and to allow the swapping of the Fab portion on these antibodies. Again, teclistamab had the FC portion mutated to allow to improve the half-life, but also minimize the cytokine release syndrome and other activation of macrophages and monocyte. Elranatamab is a very similar molecule. That's actually a mistake on this table. It shouldn't be a duobody. Duobody is a just manufacturing process that's been developed by Genmab, so it's unique to the Janssen group, but it's an IgG2A bispecific antibody, otherwise with very similar structure to teclistamab. I will mention a couple of other molecules on this table. ABBV-383, it's slightly different. It's a IgG4 bispecific antibody, but in this case, the molecule is asymmetrical. It has 2 valency for BCMA instead of 1 binding domain for BCMA. And also the manufacturing or the development of CD3 Fab antibody, they do inform us that the CD3 was designed in a way to have very low affinity for CD3, again, to avoid the trapping of the antibody in the serum, but also it's been designed supposedly to enhance the binding of effector T cells and minimize the binding of Tregs. Because remember, CD3 is expressed on all T cells, and in theory, you can even pull Tregs from the peripheral blood to the bone marrow. It's something you don't want to happen. You want to preferably bind the effector T cells. Again, whether this truly happens in vivo or not, but this has been, at least from a manufacturing point of view, the way they selected the CD3 Fab binding moiety. And I also mentioned on the bottom of the slide, alnuctamab is another asymmetrical molecule developed by BMS or Celgene that also is asymmetrical and have bivalency for BCMA. So again, it's really, there's over 100 designs of this bispecific antibody structure, and they all differ slightly in their valency, how they bind CD3, affinity to binding CD3, but also whether they have an active FC portion or not. How about teclistamab? Teclistamab, again, is the first in-class bispecific antibody that binds CD3 and BCMA. The Majestic program has been studying the development of these molecules and has been through multiple trials from a dose escalation phase 1 trial and more recently in combination trials with daratumumab and also with immunomodulators, and now is being studied in the first-line relapse, but also upfront study are coming soon in combination with daratumumab. The recommended phase 2 dose of teclistamab is 1.5 milligram per kilogram given subcutaneously with a 2-step-up dosing of 0.06 and 0.3 milligram per kilogram. And you will see this is a theme repeatedly happening now with all bispecific antibodies, where initially we're using the full dose on day 1. Now we learned that with step-up dosing, we can minimize the rate of CRS and minimize the side effect of these molecules. The Majestic 1 trial enrolled patients who have at least 3 prior lines of therapy, including proteasome inhibitor, immunomodulators, and anti-CD38 therapy. In this particular first study with Majestic 1, no prior BCMA was allowed on this study. As I mentioned, there was 2-step-up dosing leading the full dose on day 8. Overall response rate in this population was largely penta-refractory. Response rate was 63%, with nearly 40% achieving complete remission and 58% very good partial remission or better. Importantly, we saw some deep responses with MRD negativity at 10 minus the 5, achieved in a quarter of these patients, 24.7%. But when you look specifically at patients achieving complete remission, 46% achieved MRD negativity. And this is, keep in mind, in a context of population who is largely at least triple class or penta-refractory, who had failed all available therapy and median 5 prior line of therapy. So quite impressive responses in this patient population. With regard to the durability of these responses, the median progression-free survival was 11.3 months, and the median overall survival was 18.3 months. At this meeting, there's a very interesting abstract presented tomorrow morning on Saturday regarding the correlative or predictive biomarkers of response to teclistamab. So it's an interesting abstract presented by the Jensen group tomorrow at 10 a.m. session. I invite you to attend that session. How about side effect and tolerance of teclistamab, in particular with regard to CRS, cytokine release syndrome? With the step-up dosing, the CRS rate has been significantly mitigated, and you can see the overall CRS rate reported in the study was 72%, but the majority of more than half, 50.3%, were grade 1. So just fever that results for 1 or 2 days, and typically happens very quickly within the first 48 hours and very predictable. Around 20% were grade 2, but again, only 1 patient had grade 3 cytokine release syndrome. Neurotoxicity does happen like we see in CAR T cells, but again, happens very quickly, usually at the same time as CRS, unlike with CAR T cells where ICANS does happen later on in the following week or 7 days. In this case, ICANS tend to happen at the same time as CRS, and the majority of it is grade 1 or grade 2, and it's reversible in these studies. As you can see, 5 patients in the Majestic 1 experienced CRS with 3%, and the majority of these events were grade 1 and grade 2. None of these events led to treatment discontinuation. So again, a very manageable neurotoxicity and cytokine release syndrome. How about elranatamab? The development program is called the Mechanism program. As you know, the phase 1 study did explore a dose escalation of elranatamab from 80 milligram all the way up to 1,000 milligram. And there was initially a full dose was given to these patients, but subsequently a priming cohort was induced with a 600 microgram per kilogram and then the 1,000 microgram per kilogram. And the expansion phase, they transitioned to a fixed dosing of 44 milligram followed by 76 milligram. And right now, there are 2 priming doses being explored or being used in this regimen at 12 and 32 milligram followed by the full dose of 76 milligram, again given subcutaneously. The fixed dosing is obviously much user-friendly. You don't have to worry about calculating the dose and change in weight. And this was based on extensive pharmacokinetics, confirming that this dose is adequate for the majority of the patients, for the overwhelming majority of the patients. In the Magnetism MM1 trial, again, this was similar population to the Majestic 1 population, at least 3 classes of drugs. Nearly 100% of the patients were triple-class refractory, and the overall response rate was, again, an impressive 64%, with 35% achieving complete remission or stringent complete remission. So very deep response in a triple-class refractory population as well. And this study will be updated tomorrow, the MM1 trial by Dr. Nupur Raje at tomorrow's session. Again, I invite you to see the update and the longer follow-up on this trial. Magnetism MM3 was the same study, but an expansion of this phase 1 explored the use of elranatamab in a patient with triple-class refractory multiple myeloma. again, refractory to IMiD, PI, anti-CD38 antibody. And in this study, we had two cohorts, cohort A with no prior BCMA exposure, and cohort B with prior BCMA exposure. And why we're looking at that? Because in the previous trial, the mechanism M1, around a third of the patients were previously exposed to BCMA, mostly ADCs, and we saw a 50% response rate in prior BCMA exposure. Therefore, in this phase 1 or phase 2 study, we're exploring also the activity of this molecule in patients previously exposed to prior BCMA, ADC, or CAR T cell therapy. At the presentation last year, this was reported to have a similar response rate of over 60%, and the median progression-free survival was reported at the median follow-up of 6.8 months. The median progression-free survival was not reached yet. Tomorrow, I'll be presenting an update of this trial. I can briefly tell you that the median progression-free survival at 9 months is over 60% as well. I'll invite you tomorrow to hear more details. So again, it seems to be very effective and durable responses in multiple relapse patients with a very durable progression-free survival that can be likely close to a year in this patient population as a monotherapy. And similar to the Majestic program, elranatamab now is being studied in combination with variable myeloma backbone therapy, including proteasome inhibitors, immunomodulators, and anti-CD38 antibodies. Now, I mentioned twice the step-up dosing and the priming in the mechanism M1 study, as well as the teclistamab program, they measured cytokine along when these treatments are given, especially when CRS occurs. And you clearly show here in the blue curve versus the red curve when we added dexamethasone for the dose 1, dose 2, and the full dose on day 3. So 3 doses of dexamethasone with the priming doses to minimize CRS. And you can see from a biochemical point of view, the use of dexamethasone in priming completely suppressed the production of cytokines like interferon gamma, anti-NF-alpha, and interleukin-2, again, almost eliminating the significant CRS, and that led to a shift in the IL-6 production. So IL-6 was still upregulated, but was delayed by 24 hours, and this again allowed significant mitigation or minimization of the risk of CRS and ICANS in this patient population. Again, with the elranatamab, the CRS rate was similar to the teclistamab. This is data from the mechanism M1 trial. Overall, CRS rate was 66.7%, 33% grade 1, and 33% grade 2. And I can tell you now with the MM2 study, we have also similar rate, majority being grade 1 and around 20% grade 2 CRS. The recommendation, again, to use antipyretic, antihistaminic, and dexamethasone only for the first 3 doses with dexamethasone to minimize CRS risk. How about other molecules? I'm going to briefly mention 2 of them. The Regeneron 5458, it's developed with a slightly different technology, but again, the same target, CD3 and BCMA. And importantly, with this molecule, again, we saw very high responses, especially at the active dose of 200 to 800 milligram. You can see an overall response rate of 75%. And we saw also durable responses with 4 of 10 patients achieving MRD negativity at 10 minus to the 5. One thing is appeared to be unique and hopefully will be validated with Regeneron. We tend to see a lower, or they have reported so far, a lower CRS rate compared to the other molecules. Again, we'll have to see with longer follow-up whether it is indeed sustained or was it just a earlier study. We need to confirm whether CRS rate is indeed lower. The AbbVie molecule, as I mentioned, like the elranatamab molecule, has a unique structure. Having the bivalency, as you can see in these 2 purple design, or the yellow molecules on the left, has 2 bivalent binding domain for BCMA. We'll see whether it's indeed result in longer duration and longer remissions. And also, like as I mentioned, the CD3 moiety have been modified to have low affinity for CD3 and to have preferential binding for effector T cells and less binding for Tregs. And the phase 1 study with AbbVie-383 has been published recently in JCO by Dr. D'Souza. You can see that the overall response rate was very similar to the previous trial, again, roughly around 60%, 57% to be exact, and nearly half of the patient achieving very good partial remission or better. The phase 1 study is ongoing. It will be updated at this meeting. The AbbVie program now is exploring multiple dosing schedule. And one thing different about the AbbVie molecules is given every 3 weeks instead of every week or every other week. So it's more user-friendly from that perspective. Update presentation will be given tomorrow again in this meeting. What do we know about the resistance mechanism to bispecific antibodies? So why not every patient respond to bispecific antibodies? So I'll explore in the next few slides some of the biological mechanism we think that are involved in resistance to bispecific antibody. I'm showing here two papers published, one from the Jensen group and one from the group in Rotterdam University, where they looked at the effect of soluble BCMA on the efficacy of bispecific antibodies. So what they're doing in this experiment, they're co-culturing myeloma cells with healthy T cells and with or without bispecific antibody, and they're spiking the culture with different level of BCMA. And you can see that with the high level of soluble BCMA added to these co-culture, we can see a reduction in the lytic activity of this bispecific antibody induced by T cell. Because again, soluble BCMA can bind the BCMA Fab moiety and trap the bispecific antibody, preventing them from binding the target on the myeloma cells. Is it really relevant clinically? You can see that what we know about the level of soluble BCMA is roughly around 15 nanomolar, or 120, and the highest level being 125 nanomolar that has been reported so far from clinical trials. So the effect of soluble BCMA plausibly could affect the activity of bispecific antibody, but really has to be very high level, at least over 150 nanogram per milliliter. So this kind of green curve in the middle to affect the activity of BCMA binding bispecific antibodies. What do we know from the clinical trial? As Nikhil mentioned, with CAR T cell, disease burden wasn't an effect. But you can see from the recent publication from Philippe Moreau in New England Journal of Medicine with teclistamab, high disease burden with more than 60% plasma cells and extramedullary disease, as well as ISS stage 3, did slightly reduce the efficacy of bispecific antibody. So perhaps with the bispecific antibody, unlike CAR T cells, where we're using a very large dose of BCMA binding cells, the level of soluble BCMA and disease burden, if it's very high, can slightly affect the efficacy of bispecific antibody. This will need to be confirmed in future clinical trials, whether indeed this is the case or not. How about the fitness or the health of the immune cells that affect the efficacy of bispecific antibodies? As I mentioned, tomorrow the Jensen group is presenting their analysis of the Majestic 1 trial, but I'll give you also a brief presentation from Dr. Neri, who will be presenting this at this meeting on Monday, and can encourage you to attend her presentation. Here we show that she studied at the single cell level the phenotype of the T cells, but also the functional fitness of the T cells. And you can see in this dot plot on the right side, comparing sensitive on the top and resistant on the bottom, that in sensitive patient, we see a higher proportion of CD8 naive T cells and a higher proportion of CD8 effector cells, effector memory cells. While in resistant patient, we see a much higher population of terminally effector T cells, we call them the TEMRA, and higher proportion of exhausted T cells, as you can see in these dot plots on the right part of the dot plot. So again, not unexpected, but this has been confirmed now by single cell studies showing that a healthier immune repertoire can lead to better response with bispecific antibodies, and therefore it'd be exciting to test these molecules earlier in line of therapy where the T cell repertoire is more healthy. How about the antigenic loss? Does antigenic loss play a role in resistance to bispecific antibody? My co-chair, Dr. Munshi, and the group from Rotterdam, as well as our group from Warburg University, had published a few years ago loss of BCMA in CAR T cells, showing roughly around 4% of the patient post-CAR T cell therapy targeting BCMA have biallelic loss of BCMA. Now, with bispecific antibody, Dr. Holly Lee will be presenting tomorrow morning a presentation on the frequency of biallelic loss of BCMA in patients receiving bispecific antibodies. And I'm showing here one example of these patients. This is single cell copy number analysis. And in the heat map on the upper left, you can see comparison of pre in green versus the orange on the bottom. And you can see the copy number gain didn't dramatically change before and after therapy when this patient progressed. This patient achieved nearly complete remission for approximately 6 months and then progressed. And you can see at the time of progression, he had gain on one chromosome 1q, and he had some gain on chromosome 7. But if you can notice that this blue line around chromosome 16, if the paint, this works, yeah, you can see this loss of chromosome 16, which was present before therapy and was persistent after therapy, but this appears to be a monoallelic loss, so only one copy loss of BCMA on chromosome 16. However, when we look closely at the locus of BCMA or TNRF17, you can see at progression, this patient now acquired biallelic loss at this locus, very focal loss of roughly 300 kb surrounding the TNRF locus. So this patient had biallelic BCMA loss at progression. Now the question always comes back, was this clone present before we give them bispecific antibody, or did the patient acquire that? So when we look at the single cell level, we can see that a very small proportion of the cells, 0.8% of our myeloma cells, did have biallelic loss present before starting therapy. And therefore, simply we've selected with the treatment this very small clone that can evolve and that the disease progression over time. What about the repeated stimulation with bispecific antibodies? We know bispecific antibody, unlike CAR T cells, are continuously administered. Does that lead to disease progression? There was a recent publication by the German group from the University of Berlin that looked at repeat antigenic stimulation as a mechanism leading to resistance. And this was done in vitro, and they showed clearly that repeated stimulation or engagement of CD3 on T cell can lead to T cell exhaustion. And therefore, they recommended using an intermittent dosing schedule. And now most of the programs are looking at using bispecific antibody either weekly or every month, again, to minimize chronic stimulation leading to T cell exhaustion. And lastly, BMS, if I don't mention infection, as Dr. Munshi mentioned earlier, because of the T cell redirection and depletion of humoral immunity with depletion of BCMA expressing cells, infection is a real concern. So I encourage you when using bispecific antibody to be very vigilant about monitoring for infection, in particular viral infection, CMV, EBV. We had a few cases of parvovirus, red cell aplasia, but also a fatal adenoviral hepatitis has been reported. So preemptive use of IVIG is important, and preemptive therapy for CMV viremia and EBV viremia is also important in this patient population. So with this, I'll stop, and I will be now discussing a brief case, and I'll ask my esteemed co-chair to give us their insight on this particular case. This is actually a patient of mine who is a 74-year-old female, IgG lambda multiple myeloma, ISS3, no high risk by FISH, so was predicted to have a good prognosis. But unfortunately, as you can see from medical history, she rapidly progressed to have a penta-refractory myeloma. She received Cyborg-D induction, followed by DRD, followed by POM index, and followed by carfilzomib index. And now she is progressing. So 74-year-old female who's quite fit, who has now penta-refractory disease. And honestly, at that meeting with her, I discussed hospice, potential clinical trial, but I'm curious whether Dr. Munshi, Dr. Gabriel, would you consider this patient at this age, 74-year-old female, penta-refractory, to be eligible for bispecific antibody? Yeah.
Okay. So I think this is a very classic patient that we see these days. 4 lines, which is what we need. He's old, but for bispecific, as you just very nicely showed, that's not an issue. So I think he's a very classic patient who should be considered for BCMA-targeted treatment. The question would be, should it be bispecific or should it be CAR T? And if both, then which one should come first? And the way I would think is that if patient has a there is no good data to support one versus another. So if one has an opposite view of what I'm saying, I think it's exactly correct as well. But if patient has a more aggressive relapse in the sense that the disease is progressing, aggressive not by the time, but at least by the nature, I might lean more towards CAR T. We get deeper responses, usually 90% plus. BiTEs give 60% response. And number 2, there is a good treatment-free interval. An old person like this would benefit from that. On the other hand, BiTEs are easy. The CRS, as you very elegantly showed, is lesser strength or lesser degree, grade 1 mainly, or occasionally 2, but not 3. And so he may tolerate it better. So depending upon patient's general condition and the disease state, I would decide between the 2, but definitely is a candidate for one of the BCMA targeting treatment.
Yeah, no, I totally agree. I think it's really a question of bispecific or CAR T, and there are also other variables there. Does the patient live close by or not? Is the insurance going to cover it? So there are so many variables that we look into, but the best thing is you're not going to hospice care, you're going to bispecific or CAR T.
And that's exactly what we did. This patient, we didn't have availability of CAR T cell at the time when we discussed. We offered her a clinical trial with one of the bispecific antibody, and indeed she went on to receive elranatamab, achieving complete remission, lasting for nearly 14 months after receiving this therapy. Now, the question comes up also regarding which molecules should be used and the difference in the CRS rate between different molecules, CAR T cell therapy, bispecific antibodies. So can you give us your insight about CRS? Is it different between all these molecules or between CAR T cell and bispecific antibodies?
I think the degree of CRS is less. The treatment is very similar. The time frame is different. They usually get earlier on, and that's why we dose escalate, or at least there is an initial getting patients in period, lower dose to start with, going higher dose. In the older days, and in myeloma old days is like 3 years ago, When patients ended up getting higher dose to start with without a run-in, there was actually a mortality with one of the CAR T studies. So having this run-in makes it much smoother, and I think that's the time when they require the management. One thing that has become very clear for CAR T and BiTE is that, again, in old days, we were afraid of treating CRS with the view that if you treat CRS, patient may lose the efficacy, and we are doing all this to get an efficacy. I don't want to kill that component. But now it is very clear that treating CRS aggressively, definitely with tocilizumab, to some extent even with steroid, does not impact significantly the eventual outcome. And so I think we're all very liberal in treating them. Sooner we treat better, especially if patient is older. I don't want him to go to grade 2 or higher CRS. And so, but between the various bispecifics, I think CRS is more or less similar. There may be little time difference.
Yeah, nothing to add.
Okay. So one more update on this patient. This patient progression actually had biallelic BCMA loss, and she went to receive therapy with another bispecific antibody with talquetamab in combination with daratumumab. And I'm happy to tell you that she also achieved complete remission, rapid complete remission, now lasting over 8 months. So the question, can we transition from one bispecific antibody to the other? And my co-chair, Dr. Gabriel, will tell us if we can do that or not from the currently available data. So Irene.
All right, well, thank you so much. And I just want to say thank you to the organizers and to my chair, Nikhil and Nizar, for inviting me to start ASH. It's an exciting time for us to be back in ASH in person. So thank you again for that. So it's going to be very hard for me to follow Nikhil and Nizar, but I'll try my best. And I said that I will speak slower than Nizar this time. All right, so I'll take you through what's left. And we talked so much about using BCMA, whether it's bispecific, whether it's CAR T, whether it's an ADC. But really the question is, can I bring those earlier? And if if anyone invites me to a talk, I usually say earlier is better, even for smoldering myeloma. So here it is, I said it. But it's a question because you have less tumor burden, which means that you could potentially have an amazing response in those patients and better T cells. We just talked about the quality of those T cells that either you're using for your CAR T or you're engaging for your bispecific. The better they are and less exhausted they are, the more response you'll have. So potentially, again, the one thing to remember is the earlier the better, potentially both for CAR Ts and for bispecifics. And then finally, I'll take you through the last part, which we all ask our questions is, I've given my patient a bispecific or a CAR T, they've progressed, now what? Can I reuse a T cell engager or not? So I'll take you through all of those in the next few minutes. So the first data is using CAR T earlier. And again, remember, we have 2 approved CAR Ts, either IDO Cell or cilta-cel. So I'll take you through IDO Cell, which is the KarMMa data. Dr. Munshi beautifully showed us before that KarMMa or IDO Cell works even in heavily pretreated patients, 4 or 5 lines of therapy. So the question is, can I take it earlier in those patients? So this is data from the KarMMa cohort 2A data, and this is early relapse after stem cell transplant. So the patient went through transplant and now is progressing. Can I give them early on CAR T and not have to wait for the 4th or 5th line of therapy? And the answer is yes. 37 patients, so it's a small number. But again, remember in CAR T data, this is big numbers so far. And the question was, are they getting high responses? Yes. Over 80% response. Are they getting a depth of response, MRD negative, that is sustained in those patients? The answer is yes. And this is critical again. The earlier, the better. You can see here an MRD sustained response of over 18 months and still counting. And then the third question is safety. Is it safe to give those patients earlier CAR T? And the answer is yes, they had the same or less cytokine release syndrome as well as ICANS. So in general, is it safe and is it effective to give CAR T in an earlier relapse after stem cell transplant? This is the first data that shows us this. Now moving on to KarMMa 3, and this is already updated that we have interim results from it. So KarMMa 3 is here asking the question, early on, can I actually give my patients IDO Cell versus standard of care? So these are patients who had 2 to 4 prior lines of therapy, so not heavily pretreated patients, and it's comparing them to either receive IDO Cell directly or any of your best regimen that you have out there. whether it's triple combinations, whether it's other combinations of therapy, and you can see all of them. So spoiler here, that the interim results did indeed show a significant improvement in progression-free survival, and this is the trend for us, using our CAR-T, our best drugs, earlier and earlier in our patients' population. So I'll go back to the KarMMa-2 data, and this is cohort 2C. And I'll ask the question, what if this patient can receive, in a high-risk multiple myeloma patient who's not responding well to their front line of therapy, so this is an earlier even case than the ones before, can I give them IDO Cell upfront in those patients? And again, here's the data from 31 patients in cohort 2C asking that question. So again, response and toxicity are critical. And here you can see that the response is over 87% in those patients. Depth of response and MRD negative is higher and higher. But more interestingly, less toxicity. So we talked about maybe if those patients have better T cells and better or less tumor burden, you may actually have a better improvement in your toxicity, so less CRS and less neurotoxicity in those patients. This is the earliest signs that we're seeing, and I'm sure that by next year in ASH or the year after, most of us will be bringing CAR-T and bispecific in earlier settings. Let's move on to cilta-cel, CARTITUDE. And these are the designs of two studies, CARTITUDE-5 and CARTITUDE-6, that I'll show you in the next slide. So this is a target enrollment of 650 patients who basically will go on to your standard of therapy, which is VRD, then you get randomized VRD again for 2 cycles, and then maintenance with Lendex. That's what we do. Now we're doing 4 drug regimens in many patients, but that's what we're doing in many of our treatment as standard of care. Now switch that and try to give those patients VRD still up front, so induction regimen, and then after your 2 cycles of bridging, now you take them to cilta-cel. And it's really a question of, can we really improve, instead of giving Len maintenance only in those patients, improve on our depth of response and long-term remission, and no need for maintenance therapy of lenalidomide forever. And that's so critical. I think if we ask every single patient, do you want to stay on lenalidomide maintenance for a very long time? The answer is probably not. They want that one and done. They want to see that they are free from drug. And this is where we're trying to move to multiple myeloma. Depth of response, MRD disease, negative disease, but also free from drug, because our patients will not say that they're cured unless they're truly out of therapy and free from it. And then the other design, which is CARTITUDE-6, and that's also exciting. That's early on, upfront therapy for those patients, and you're going to ask, best treatment that you have so far, 4 drug regimens, their RVD, transplant, their RVD for 2 cycles, and Len maintenance. That's what we're giving to every single patient we see today in the clinic, compared to now give them their RVD for 6 cycles, but then take them to cilta-cel and still give them 2 years of Len maintenance. And we will see if the depth of response, if the progression-free survival in those patients, if we can potentially cure many of those patients by earlier giving them cilta-cel instead of transplant. So the trend of now, whether actually CAR-T will be better, safer, less toxic, but also more potent than stem cell transplant, the one thing that we've been using for many, many years and has not been displaced so far, transplant, will it ever be displaced? And potentially CAR-T might be the answer to displace it. So this is the CAR-T data, and then the question would be, can I use bispecifics? And again, we've talked already about how bispecifics are critical for us because they're easier to give, they're off the shelf, and you can give them to everyone in the community. So it may be easier for you to have access to it. So how can I use them at an earlier setting? So we note that teclistamab is FDA approved now for relapsed refractory multiple myeloma. But again, 4 or 5 lines of therapy, can I bring it earlier? Not only that, can I give it in combination? Because we're now using it as a single agent. So can I start using daratumumab with teclistamab? Can I use lenalidomide with teclistamab? And the answer is yes. You'll see here an oral abstract presentation showing you that you can use teclistamab with daratumumab and with lenalidomide. So again, now we're starting to say I can do the T-cell engagement, but I can also enhance it with lenalidomide or with daratumumab. And this is another one, again, where in the maintenance setting, can I have teclistamab added to my lenalidomide to really improve on that T-cell engagement and long-term remission in patients with an MRD assessment in those patients. So again, depth of response as early as possible with T-cell engagement in those patients. So the biggest question that we have is, I've given my patient the CAR-T, I've given my patient the bispecific, I've heard the amazing responses from all of us, and yet my patient is progressing. And this is happening to all of us. Unfortunately, our patients are still progressing on therapy. Sometimes for a long time, they've been in great remission, and sometimes it's a shorter duration of therapy. And again, mechanisms of resistance are so critical for us because we want to be upfront selecting our patients who will benefit from it rather than waiting for them to progress 2 or 3 months later because we were not selecting them well. So the more we have biomarkers for who will benefit from therapy early on, the better we will be able to say this patient will have long remission and this one will not. So let's talk about how can I sequence my therapy. And again, I'll talk about both bispecifics and CAR-Ts in our patients. So here's some of the data from Majestic, and this is cohort C. And here what they did is they looked at teclistamab in patients who had received prior BCMA therapy. So this could have been belantamab, ADC, or CAR-T exposed, 15 patients, or any of them, including other CAR-Ts. So again, trying to ask the questions of, can I really give a BCMA after a BCMA? And you can see here again that the responses were pretty impressive despite having a prior BCMA. Now again, these are not the patients who had complete biallelic deletion. These are not the patients that you can say they don't have BCMA expression. So you have to be careful. We're not saying don't use your biomarkers and just treat anyone with BCMA followed by BCMA. We're saying that if they've been exposed to BCMA, they're still expressing it well, then there's a potential of retrying again another targeted BCMA, whether it's an ADC or a CAR-T or a bispecific in those patients. And then if we look at elranatamab, I have to say it correctly like you, so it's elranatamab. Only Nizar can do it correctly. And here you can see that indeed those patients, half of them had an impressive response, complete remissions, and depth of response of CRs and MRD negative, even if they've been prior exposure to BCMA-targeted agents. Again, most of them either ADCs or other bispecifics or other CAR-T therapy. So this is yet one more piece of data from another drug, but yet BCMA bispecific antibody, showing you that you can still achieve deep remissions in your patients, even if they've been exposed to prior CAR-T or prior bispecifics. And this is actually a very exciting data. So this is from Sinai and Tariq Muddin, who put this data together and published it. And it's actually, he used to be a fellow with us at Dana-Farber, put together the experience from Sinai of 115 patients who were enrolled on clinical trials with bispecific antibodies and asked the question, now what? They've progressed. How can I treat those patients again? So as you can see here, 63 of those patients came off the bispecific antibody. And the question was, do I treat them again with a CAR-T or a bispecific, or do I give them traditional chemotherapy, stem cell transplant, DSAP therapy, and so on? And this is critical because we're asking that question every single day in clinic. Do I switch therapy or not? And the answer is here. Again, these are still small numbers, but this is real-world data. This is data from our own patients. And you can see those that received bispecific, so 10 patients, CAR-T therapy, 9 patients, and ADC, 3 patients. In general, all of them had an improved progression-free survival when you have a T-cell engager used instead of traditional chemotherapy. So again, it's coming back to the question, this is not just BCMA targeting, this is really trying to still engage your T-cells in those patients, whether they had CAR-T before or they had a bispecific before. So trying to still use those potentially different ones, different BCMA versus GPRC5D or FCRH5 and so on in many of those patients, but still trying to use your T-cell engagement in your patients. And then a couple of slides here showing you again, can CAR-T therapy be used in patients with prior exposure to BCMA therapy? So again, we talked about bispecific to bispecific or bispecific after CAR-T. Now can I reverse it? Can I use the CAR-T after a bispecific? And I think this is critical for many of the patients, especially people who are treated in the community, because it may be easier for you to have access to a bispecific, but then once your patient is progressing, you're starting to say, okay, now I'm stuck. I want to use my CAR-T. And this is critical for us all to know that we can use one after the other. Now, here's some data, real-world data again, from people who had CAR-T, whether they had a prior BCMA bispecific or CAR-T also, or an ADC. And again, you can see that the numbers are still very small, but there is a difference in some patients who were completely naive and never had BCMA exposure versus those who had some exposure. Again, in general, you're still responding, but there is a little bit of worse outcome in patients, especially if it came one after the other. Likely, again, because how potentially either mechanisms of resistance of exhaustion of those T cells or deletion of BCMA or low expression of BCMA. So we need to still understand it better, likely because you don't want to expose patients to therapy when you know they may not respond to this therapy well. So the more we have biomarkers up front, the more we will be able to have better selection of our patients. And then yet one more data of CAR-T, and this is from the CAR-T2 cohort. So this is 20 patients. And you can see here, if you look at the full cohort versus those that were exposed only to belamaf and ADC versus those that were exposed to bispecific antibodies before, so 7 patients or 13 patients. So not a huge number of patients here, but you can see here the overall response rate was not a huge difference, except that those that had bispecific and then CAR-T was slightly lower, and also the same thing for the VGPR and depth of response in those patients, slightly lower than the general population. So there might be some differences between a bispecific and an ADC, again, potentially because of the T-cell engagement in those patients. The numbers are small, but we need to have that data to understand better who will be selected from one therapy to the other in the near future. So moving on from BCMA to other potential targets. And the nice thing is that it's amazing how we can keep getting more and more drugs in multiple myeloma. I remember I was trained over 17, 18 years ago when we were still using dexamethasone, our standard of care, and then we started doing thalidomide and dex. And here we are getting not only amazing drugs for BCMA, but moving on beyond BCMA into GPRC5D, FCRH5, and hopefully more and more of those in the near future. So let's talk about some of those. You've already heard a little bit about FCRH5, cevostamab. And I think the nice thing here that will be presented this year in ASH a couple of days from now, so Saturday, actually tomorrow, we will see that this is a fixed duration of therapy for cevostamab. And this is, again, one of those ideas that we're trying to get to. Let's not treat our patients indefinitely. And potentially this could be very useful for not exhausting all of those T cells as you retreat and retreat, but also the infection risk that we see with our patients, because we've seen that the problems are infection much more in those long-term T-cell engagement of our patients compared to the short-term toxicity that they have. But again, you can see here impressive responses with FCRH5, with cevostamab, even if those patients have been heavily pretreated before, and hopefully we will see more data from this drug. And then, of course, GPRC5D, and this is just showing you one of the data from talquetamab, and this is ongoing right now, but talquetamab was tested with 2 different doses, either weekly or every 2 weeks. And again, this is coming back to the question of how much we can give those patients and how often do we have to give them. So you've heard already from Nizar that less often is better for us. And here you can see that the 800 microgram per kg every 2 weeks was also tested in those patients. And both arms, whether the every 2 weeks or the weekly, had impressive responses and moving forward potentially with the 2 weeks in all of those patients. But again, high responses and less toxicity. And in general, we're seeing that talquetamab may have still the same toxicity that you see with teclistamab, but potentially maybe other toxicities because of the taste buds and the other toxicities that we see in our patients. So I'll stop here and go through a couple of cases again and invite Nikhil and Nizar to help me with them. So the first patient here is Samantha, 70-year-old woman with relapsed multiple myeloma. And she's coming in, she has CHF class 2. She had RVD induction, stem cell transplant, LEN maintenance, was in a complete remission, but progressed 5 years after, had DPD, had a VGPR in it, and then again, shorter duration, as Nikhil talked about, with the rising M spike. This time had carfilzomib, Cytoxan, and Dex, and then progressed, and then SVD, and then progressed again. So now she had belamaf, but progressed still after 14 months. So she just got exposed to a BCMA. Would you consider giving her, again, another BCMA after the belamaf therapy? Nikhil?
Yeah, so I think this patient, so one thing we need to remember about BCMA targeting drugs, that unlike what we know about all other drugs, so for example, proteasome inhibitor, you have bortezomib and carfilzomib, they are going after the same target to kill the cell. The BCMA targeting treatments are not going after the same mechanism of killing. So if you take belamaf, it is mechanism of action of killing is through the payload that it gives. It's more anti-tubulin drug. Versus if you look at bispecific, activates the inherent T cells and then killing. And then CAR T cells are produced outside and then infused to have that effect. So the mechanism of killing is very different. So what I mean by that is that if you are resistant to one, does not necessarily mean at all that you are going to be resistant to second and third. Yes, the target is same. And as BCMA loss is not frequent, even the second and the third BCMA targeting drug is going to work. And so I would submit that one should try all three choices, if available, in some succession. So if this patient got belamaf first, I think he would be eligible for CAR T and or bispecific, depending upon availability and which one he has access to first.
Yeah, I fully agree with Nikhil. As I showed in my presentation, the loss of BCMA, and as Nikhil published as well, in post-CAR T-cell therapy is very low, less than 4%. With the bispecific antibody, it appears to be slightly higher. Nikhil is roughly around, Lee will talk about this in a presentation tomorrow, probably a third of the patient, we see loss of BCMA with the bispecific antibody. So as you said, Irene, as long as the patient has confirmed BCMA expression, I think she will definitely benefit from bispecific antibody. It should be tested and treated with this option.
And we're starting to see also combinations of GPRC5D with BCMA in many of the patients that we're treating now. So again, more and more of data for our targeting multiple targets for our plasma cells. So we'll move on to our patient, and this is a 60-year-old patient with standard risk ISS, and he was treated with RVD induction, stem cell transplant, LEN maintenance, had a complete remission for 3.5 years, but progressed, had DCD, and then had VGPR again, so impressive responses, and does have access to specialized care, which, something that we should not be having as an issue these days, but this is yet another big question of how can we improve access to all our patients and not to some of our patients. So the question is, can you give early CAR T therapy in those patients, and which one, and what are the benefits of earlier therapy in those patients?
Okay. I was going to say there may be some differences between the Canadian system and the US, but given a choice or access, I would definitely consider this patient for BCMA targeting treatment. In definition, it's only second line, so patient is getting third line. But as you showed very elegantly, that's where it works beautifully well. The PFS is great. It's still emerging data, but I think there is enough data to be so comfortable with it. The main problem ends up being access. And so he has access to specialized care place, but he probably will not have an access to each of the three drugs, the belamaf, teclistamab, and either of the CAR T, because they will only qualify when they have 4 lines of treatment. And I think this is the classic scenario that we face so often these days, that how can now I get this patient to be eligible for CAR T or some BCMA targeting treatment? And I think that's there is no easy solution except, as Irene said, we work together and have FDA get the data to approve it at the earlier line of treatment. But medically speaking, I would definitely consider this patient for CAR T cell in a heartbeat.
One question that we get a lot, and maybe I'll ask you both, is now that we're starting to think of collecting T cells early, should we be thinking of collecting them early in our patients? And then if they needed second, third, fourth line, they were the best T cells at least, rather than waiting to collect them after the third or fourth line. So I'd love to hear Canadian and US experience, or not experience because I don't think we're doing it yet, but potential benefits.
Potentially, yes, the answer is collecting T cells earlier will lead to better T cell product and better CAR T cell product and outcome in these patients. But the data is yet to be seen. But biologically, yes, it does make a lot of sense. Now, as you mentioned, Irene, we have the result now of the KarMMa-3 trial using CAR T cell earlier line of therapy. The study is positive. We need to see what is the depth of response and duration of response in this population. And we have multiple continued program looking at earlier line of therapy. I'm a little bit of actually the belief that with CAR T cell probably doesn't matter because it's more relays on your manufacturing in vitro. So likely the duration and depth of response will be similar, whether you use it late on or up front. But we need to see the data, I guess.
Nikhil.
Yeah, I think the critical question, and Dr. Balis and I think his lovely wife, Dr. Neri, has studied this about the T cell fitness and what T cells are good to produce the best response. And there is really good data that if you collect not so good T cells, they're exhausted, you may not be able to have as good a response with CAR T cell. It's still emerging data. So I think in some ways your question is very appropriate. Can we collect early? And what one may not be as clear about what is early. When will we collect would be the best time? Would it be post-transplant if the patient is getting transplant, post-best induction? Should we collect while getting lenalidomide or some such immunomodulator? And that remains unclear. So currently, and also in our real world storage, how long would we store, etc. I think there is also another issue about early collection. Both of the products, cilta-cel and IDO Cell, and correct me if I'm not right, they require freshly collected cells to produce. So on the research side, we can do this. On the commercial side, we have to go with their algorithm, what they are set up in producing it. And so because of that, although we all three agree we should collect early good quality cell, in practice, we may not be able to do it. One question that I often get is, can we use the old stored stem cells? Because our patients all have stem cells stored. We use one part of it and the other part is there. Can we use it? Theoretically, yes. Practically, no.
We want to thank HealthTree for multiple myeloma. Again, Jenny, thank you for being part of this. It's very critical for us to have amazing patient advocacy here. So thank you for your support of this program. And with that, I'll give it back to Nikhil.
Oh, thank you very much. And I think it has been a very good summary of the landscape of BCMA targeting treatment. And you, I'm sure, could feel the excitement on our side, and I can feel the same on your side, that this is giving us unbelievable responses that in our lifetime, in 30 plus years, not all of them, we have not seen something like this happen. So there are a number of questions already here, and I can start with those questions. So one of the question is, and that Irene touched on, but what could be good post-BCMA options? And there are two parts to the question, I would say. One is post-BCMA CAR-T with BCMA targeting, which we discussed with your case, but what else can we do? And these are patients who had 6 lines of treatment and then they got CAR-T. What would you consider for these patients later on?
Well, Irene did touch on this answer already. We can clearly cross from one bispecific antibody to another bispecific antibody. So transitioning from a BCMA targeting to FcRH5 to GPRC5D, and clearly we see responses in this patient population. We can also transition, in theory, to your previous line of therapy if the patient has been refractory to another line of therapy, whether it's selinexor or potentially even belantamab, if it's going to be available again on the US market. Now, the only thing that we have some hesitance about the transitioning is from bispecific antibody to CAR T cell therapy, because the data so far suggests that harvesting T cells after bispecific antibody, you're likely harvesting exhausted T cell, and therefore the quality of your product will be suboptimal. Responses don't seem as good. So as far as sequencing, always sequence CAR T cells before bispecific antibody, purely because of the harvesting issue of the T cells.
Yeah, no, absolutely. And I think the one thing we're starting to think about now is whether, if I had the choice of a BCMA versus a GPRC5D or FcRH5, would I want to switch or not? And I don't know if there is a good answer for that, but absolutely, it's a great idea to think of BCMA and then what, but CAR-T first and then bispecific.
Yeah, so in that, I think GPRC5D, this is still investigational, although the bispecific is quite advanced with large data that Dr. Gopial showed. But it seems, and this is early days, that GPRC5D may lead to lesser immunosuppression than BCMA. If that pans out, then one may use that first and use BCMA targeting CAR-T later on. The second point also is, and which is good, that both of them work with prior exposure to others. So those who have had prior GPRC5D, very small number of patients because it's still early days for that CAR-T. But some of those patients, when they get BCMA targeting agent, they still respond. And other way around is very clear. Those who had relapsed from BCMA CAR T cell would respond to GPRC5D. So I think that knowing that relation is quite important. One more point I would like to make is that patients who have relapsed from CAR T cell treatment for not so clear reason, and I would love to see what my colleagues think, but they do become sensitive to the agents that they have received before. Now, which one, how, remains unclear, but we have had patients where they had, say, lenalidomide, and I'm just picking a name, before with resistance. Now, post-CAR T cell, they might be resensitized, not as a single agent, but in some combination. So I think because of the cytokine release syndrome causing real great upheaval in the immune system, in the microenvironment, you may want to consider some agents that you thought were not totally resistant, but not so sensitive, and then you can utilize. So I think both of you have worked great deal on microenvironment. Any comments on how post-CAR T cell microenvironment might facilitate something later?
I mean, that's absolutely true, Nikhil, because with CAR T cell therapy, as Nikhil have showed us and Irene, we have such a deep debulking of the disease. So you're almost resetting the whole bone marrow environment. So whatever cytokines, IL-17, other suppressive cytokine produced in the bone marrow environment, with CAR T cell therapy, you're going to completely restructure your bone marrow environment. And not only that, probably the emerging clone you're having is a clone completely different from the clone you went into before CAR T cell therapy. So it's an unknown area clinically, but biologically, it makes a lot of sense to go back and retest drugs you previously been exposed to see whether they're active. And in particular, the immune environment is dramatically reset post-CAR T cell therapy as well.
Yeah, I think we are in an amazing immune era, right? And we're starting to learn again and again how to use our immune system for our benefit and really manipulate it in the right way. And we will learn not only about how different subtypes of the T cells, but also the other non-T cells, B cells, macrophages, monocytes, and also the stromal cells and their contribution to drug resistance or immune resistance. So there is a lot for us to learn. I'm very excited to see your data on single-cell sequencing post-bispecifics. So thank you, Paula and Nizar, for doing that amazing work. But the more we get to understand it, for two things. One, identifying patients early so that we're not exposing patients. The last thing you want is take someone all the way to CAR T, and then 2 months later they progress. And we need to do much better for our own patients, for their own benefit, not to make them go through that. And we are smarter than this, so we shouldn't be doing it, haphazardly. And two, post-therapy, can we identify the patients who will truly have this amazing immune response? We started to look at that in smoldering myeloma, where we have this immune normalization post-therapy, and I'd love to see it in all our patients where you have this complete normalization of the immune system. Will that reflect a long-term outcome, or are we seeing potentially Tregs emerge, exhausted T cells, and what is the question that we can target specifically for our patients in the future?
Good. So there's one question about which bridging therapies do you use in real practice prior to CAR T in triple-class refractory patients? So caveat is they are triple-class refractory, so what would we use for bridging therapy? On studies, there are limitations, but in practice, we can use whatever we want. So any thoughts you can give about what one would do?
Yeah, I mean, I use whatever is available for this patient. My goal only is to temporize the disease and prevent it from rapidly progressing. The only possible drug I would avoid, possibly alkylating agents, although you already have harvested your T cells, so it doesn't really matter. But remember, alkylating agents can lead to more infections and complications. So I typically just use whatever therapy is available to allow some temporization of the disease and prevent it from rapidly progressing. I don't think we have any data about whether any bridging therapy, if anything, data suggests bridging therapy didn't impact the outcome of CAR T cells, whatever regimen you used. I had some hesitance about using daratumumab as a bridging therapy because of the potential targeting of CD38, and CD38 is expressed in activated T cells. But the actual, if you look at the KARMA trial or the CAR-T2 trial, patients received daratumumab as a bridging therapy, had no impact on their outcome. So it doesn't look to affect the health or the persistence of the CAR T cell either. So I don't think I have any preference, Nikhil. I'm not sure what you and Irene do.
No, I think we brought up bendamustine, maybe not. So a few things, maybe not, rather than maybe yes. Mm-hmm.
Yeah.
Any preference for you, Nikhil, on that?
Yeah, no, I think you nailed it, that whatever works and whatever is available. The point ends up being that there is good data that if we have, and this is for the commercial purpose, not for the studies, but if the myeloma burden is less, the toxicities with CAR T or even BiTE would be lesser. In BiTE, bridging therapy is not an issue. So anything that will possibly lead to cytoreduction and decrease tumor burden would be the way to go. you can pick the same that patient has received, most likely not the best choice because they have been resistant to that. And so whatever alternate combination ends up being as a choice. One of the question is about the person asking this question. She says, I'm interested in allo CAR T cell. So any view on allo CAR T cells, its place in what we do? They are effective. Allo CAR T cells, there are multiple products, 2 or 3 companies have ongoing study, phase 1, 2, and the response rates are in 60% plus range, so they are. So any view on that, and where would it stand?
Yeah, definitely. There's several allo CAR T cells being tested. The one presented by the group in MSK last year at ASH, allo CAR T cell does induce deep responses. The only question about is about durability, and that's not surprising because you have some minor HLA antigen miscompatibility, so likely allo CAR T cells won't lead to as resistant CAR T cells and durable responses. But it's a very good option for patients who have lymphodepletion, who have low lymphocyte count, where you cannot harvest their own T cells to make adequate CAR T cell product. And the advantage, obviously, there you're harvesting potentially healthy T cells, not exhausted, so a CAR T cell product quality would be better. Again, the data is still very preliminary. The small data presented last year by Dr. Milandowski from MSK suggests it's feasible, it's safe. Deep responses, around 70% responded, but the duration of response seemed to be a little bit shorter, around 7 to 8 months. So we need further data on that, but it's definitely an appealing option off the shelf for this patient population.
Yeah, I mean, we are in the infancy of our CAR T, and we'll probably go back 10 years from now and hopefully look at, say, oh my goodness, we were still using CAR T the way we used to use it. But that's the beauty of science and improvement. So allo CAR T, rapid production, all of those things that can improve on the CAR T and make it much better, potentially specific targeting of certain T cells and not just bringing all CD3 T cells and so on. So there are lots of questions that we can ask to improve on CAR T. Allo being off the shelf would be great because then you're not waiting for that patient for several weeks for you to be able to give them the CAR T.
Yeah, very much so. So one more question is also interesting, and I think Dr. Ballis, you mentioned about it. The question is, can high levels of soluble BCMA impair response to anti-BCMA CAR T cells, BiTE or CAR T cells? And then in that setting, would GPRC5D be a preferred option, keeping that in mind? And so I think you've showed data about bispecifics, and that some have impact, some do not. CAR T-wise, any comments, both of you, either of you? Because the bottom line ends up being whether the antibody binds to soluble molecule or not.
So again, the premise of the question is very valid, and it's a concern we all had with patients with high disease burden, whether soluble BCMA can saturate the antibody, whether it's belantamab or bispecific antibody or the SCFV binding portion of your CAR T cells. Like Nikhil showed us from the clinical data, it doesn't seem that disease burden affect the CAR T cell outcome, which is good. And we have some preclinical data, again, by Dr. Hawley in our group, where she did study CAR T cell and the spiking culture in vitro with bispecific antibody, with soluble BCMA, that didn't seem to affect the efficacy of CAR T cell in vitro. So probably the SCFV portion sticking out of the cell, and probably because of the density of the T cell, you have millions of T cells being infused, is less susceptible to the effect of soluble BCMA. But this, again, needs to be studied more carefully. Now, GPRC5D, a more appealing CAR T cell from that perspective, again, because GPRC5D isn't being shed, I would say yes, that's likely to be more effective CAR T cell and more durable. But again, clinical data will be the judgment here. But biologically, it makes sense. I don't know if you agree, Eileen.
Yeah, no, absolutely. And it's such a great question. We know for bispecific, there's that sync. The question is whether CAR T is the same, and likely not, at least from the data we've seen so far.
Yeah. So one of the questions is, and I can answer, is about what can you do to deal with and prevent delayed neurotoxicity associated with CAR T cells. And so, as I had mentioned in my presentation, that cilta-cel had, in the CARTITUDE-1 study, had small number of patients who did get delayed neurotoxicity. Delayed neurotoxicity is one which happens usually after a month, when the real early regular neurotoxicity, the ICANS, have appeared and disappeared or resolved. And they can go up to almost 3 to 4 months, 30 to 100 days. They come up with various features, including Parkinson-like thing, and it is a serious side effect. What was done very well to identify was what causes it. And there were two reasons that are very clear. One is the patients who get it have high tumor burden, and when patients are not picked for this toxicity and treated quickly. So one, early diagnosis, decreasing tumor burden are the two things. And so what has been done quite diligently, and especially on the practice side, is that we do try to cytoreduce patient. If patient has a huge tumor burden, bone marrow 100%, I would try to cytoreduce before considering. And number two, patients are followed very diligently with writing, because micrographia is an early sign of late neurotoxicity, and if you see micrographia, you would intervene with steroids, so desiluzumab, and other appropriate treatment for it. And so I think early diagnosis, decreasing tumor burden, has been an important component of mitigating occurrence of late neurotoxicity. The second point to know about late neurotoxicity also is that it could be a potential on-target off-tumor effect. There are a small number of cells in brain, in substantia nigra, in the third foramen area, which do express very low level of BCMA. And there was a paper published that showed that maybe that is the area which can be targeted in some patients, not clearly why, especially at a high level of CRS and other. So that remains open. Occasional patient with similar symptoms with other CAR-T has been also anecdotally reported. But I think the two mitigating measures proposed for cilta-cel should probably and could be applied everywhere to mitigate that. So one more question here is, which is more philosophical question, and it applies to not just CAR-T, but probably what we do in general for studies in myeloma. And in the FDA meeting you mentioned, this was one of the issues. So the question is, will we ever have strong enough data to demonstrate an overall survival advantage? So I would have both of you answer, and then we can also discuss what is right and wrong. And the bottom line of the question is that now we have all moved towards it, and you saw all of us showing both PFS and OS data. We talk much more about PFS for various good reasons, and OS is not so critically important, and we may not even see the big difference in curve. Although in old days, again, OS was the ultimate endpoint, because if patients live longer, the rest doesn't matter, sort of. So any comments on this evolving concept of lack of significance of OS, or can we get it?
And I think you could probably be the best one to talk about that, given the recent FDA IMS discussions. But if you look at the relapsed refractory, heavily pretreated, sure, you can show overall survival benefit, because still those patients have a poor outcome and very poor overall survival. But the earlier treatments, newly diagnosed patients, we're going to wait another 20 years probably by the time we see any differences, and maybe we won't see them because you're salvaging your patients so well, and that's good, that's not bad. So not seeing an overall survival difference is not a bad outcome. It's actually a testament that we're doing such a great job salvaging our patients, and should not be the measure anymore of how good our responses are. My hope, and hopefully you will make that answer happen, is MRD measurement as true endpoint, rather being a biomarker or a surrogate marker, because it may give us that depth of response, sustained MRD, as a true outcome for our patients, and that will change for us, not just for our patients, but the rapid then approval for many of our drugs, which is at the end of the day, the benefit for our patients. So I guess, Nikhil, you're the one who can answer that question.
Yeah.
No, I fully agree. I mean, it's very challenging to show overall survival in multiple myeloma, because many patients go to very effective therapy. For example, in the KarMMa-3 trial you mentioned, Irene, 60% of the patient crossed over on the control arm to receive IDO Cell and CAR-T cell therapy. So it's very challenging to demonstrate overall survival. So my take on it, unless it shows worse overall survival, I don't think we should use that as an outcome to decide on efficacy of the efficacy.
No, I think that's absolutely the right point, because in theory, no patient should be left without an effective treatment. And so how can I judge or observe overall survival difference when I did something in the induction? So for example, when we the early studies, second-line patients getting CAR T cells or patients getting BiTEs, they're going to get 4 more subsequent line, and that is going to impact their outcome and overall survival. The bottom line, which is so positive, is that overall survival in general has tremendously increased. In what used to be 3 to 4 years at the maximum, now patients are 10 plus years median for overall survival. So we may have made a great progress. There are 2 more questions before we sum up. So one question about is persistence. And the point being, does persistence of CAR T cell in circulation matter? And should we make an attempt to have that, or probably that is not as necessary?
I mean, the question the answer is unclear. I've gave you many unclear answers, but I'll give you the data. So what we know from the CAR-T2 trial, for example, and the KarMMa trial, that none of the CAR T cells persist beyond 90 days. The majority of the patient, the CAR T cell is completely cleared and no longer detectable, at least by our technology, PCR or flow cytometry binding for a BCMA-labeled peptide. So the data suggests, and there's no correlation between the persistence and outcome. So that's what the data suggests in myeloma. On the other hand, you look in the lymphoma data, you saw a recent publication from the group in UPenn that some of the patients with the longest remission, up to 10 years, they still have persistent of their CAR T cell product. Interestingly enough, it's not CD8 T cells, but CD4 T cells, which is a bit intriguing. So they're suggesting that perhaps those phenotypic expanded CAR T cells over a long time, they're like your memory cells or vaccine-like persistent cells that can give you this long-term remission. I believe persistent is important, but I don't have the data to support what I said. Biologically, it makes sense, but the clinical data doesn't support that yet.
Yeah, I feel persistence is slightly overrated. I think it's necessary to an extent, but very long persistence, whether those cells are doing something or not, number one. And number two, are they causing immunosuppression, for example? And is that beneficial or not? So I think the jury should be still out, and we can conclude, but there is a role for certain level of persistence. But do we need CAR T cell persisting for 12 months? Remains open question.
Yeah, and it opens the question of, can we reinfuse potentially in some patients? Again, maybe based on progression, based on relapse rather than persistence or not, but it brings back that question of reusing the same CAR Ts that you had before.
So the last question for discussion, and that's, you can say, elephant in the room, is the expense. All these treatments are expensive. Any general comments about what it means to the patients, the access to the drug, or has patients not been able to get something because of that? I mean, this is the price we pay for innovation, but how much price? And it's not an easy question to answer, and there's no clear answer to it.
No, but we should do the economics of our drugs and what it means for us. But it's also important to think let's say $500,000 CAR T versus maintenance with lenalidomide for a long time, or one therapy after the other, after an admission after another. So it's not just the economics, but it's also the effect on our patients and their quality of life. And if you put those two together, I would rather say use your CAR T upfront and stop therapy, which is the question we're all saying, let's not have that maintenance of therapy forever. And it may actually be more economic for our health care system, as well as for our own patients, their own life going to work, their own family. So there is beyond just the economics of how much it costs for insurance or for the healthcare system, there's also the socioeconomic part of our patients. And I would say more important than anything is access to all our patients. So diversity, inclusion, and equity is so important now with all of those amazing drugs, having them available to every patient, not to the select patients who can afford it.
Yeah, absolutely. I mean, I come from a Canadian practice, and healthcare expenses is more than 50% of the budget of the Canadian government in every province. So it's a huge burden. So having very expensive drug is an issue. Having said that, as Irene said, if I can use the therapy early and effectively put this patient back into real life, being productive, contributing to society, that by itself is economically a factor that doesn't get accounted for when they look at the absolute number. But one potential solution for expensive CAR T cells, also academic CAR T cells. We saw our colleagues from Spain produce their own CAR T cells, and it's a fraction of the cost, and it's extremely effective. So that could be a potential remedy for the high expenses for these CAR T cell products.
Now, I think, this question is going to be remaining with us for a long time about the expense, but not to end in a downside, I think there's been a tremendous progress, great improvement in survival of the patient, and patients are beginning to have access to this technology, whether one form or another, all across the world. And I think we are so blessed as physicians to be able to use it and provide our patients care that they need, etc. So on that good note, I think we conclude today's thing. Thank you very much for attending.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/KTZ860. This activity is supported by independent educational grants from AbbVie, Bristol Myers Squibb, Janssen Biotech Incorporated, administered by Janssen Scientific Affairs, LLC, and Pfizer.